in. So I am gonna make a motion to postpone the review of the minutes until next month.
I will second that.
Is there any discussion that we want to have on this topic right now?
I think
Go ahead,
I know.
Carol. Yep.
I would just say, that I believe it's important moving forward to try not to delay, getting the minutes out to the members of the committee. There are a lot of important discussions that need to be had sometimes. And I don't think those opportunities should be delayed.
Thank you, Carolyn. And I just wanted to also mention too, that I know that when I first became chair, there was a real lag in getting minutes, and we kind of said that we needed a minimum of 1 week in advance, but the bylaws should say 2 weeks in advance. And so I agree with Carol, getting them automatic. Is there any other discussion on this? All in favor of postponing, say aye. Aye. Aye.
Aye.
Any opposed? Right, we will review those minutes next month. Next on the agenda is if there are any agenda items that folks would like to talk about. We have a bunch of things on the list that we're tracking for future meetings. I will not go down and read through them. Folks that have the agenda, you can read through those. Other than those that are on the list, are there other items that folks would like to add to the agenda for the upcoming months?
Lisa Adams.
Lisa?
Yes, hi, can you hear me?
Yep. Yes.
Yes, hi, I'd like to add some agenda items. We would just like to discuss some issues that we're having with WellSense and some of the MCOs in regards to a possible policy change that we are not made aware of. We're having very difficulty getting approvals for home health aides, and we just want to know if there's been any changes from the site so we would like to add that to the agenda. And then also we would like to add, put on the agenda about the having the agencies, excuse me, I'm trying to read my notes, I apologize, that the agencies are losing hours, or the clients are losing hours due to KeyPro assessments with people that have chronic conditions with no changes. They're giving the last minute notice of appeal so that the clients are unable to appeal. So we'd like to add that to the agenda to see if there's been any changes to the MEAs that are being done.
Yes, go ahead, Carolyn.
Lisa, are you talking about the individuals who are being closed under medical review?
Being closed and a decrease in hours.
I would second adding that.
Yeah. I know that Gina emailed myself, and we have made a request to the department to have this added. I think that it's appropriate to add those. And we are recording the meeting, right?
Yeah.
Okay. Wanted to make sure.
Thank you, I
Are there
appreciate that.
Yeah, any other folks have items they'd like to add to the agenda for upcoming meetings?
Holly, just for the committee's interest and benefit on the WellSense issue, I think we had got a report that I know our team is already looking into that issue. And then on the MEA matters where we have solicited example cases, I think we've gotten over 20 from different agencies, and we're doing a deep dive on them. And we're making progress on a number of factors, which we might talk about later in the meeting, just.
Okay, great, thank you.
And the other thing, Henry, that you're working on, I believe, a number of the agencies have asked for a list.
That's one of the, I can take it up now. So we've been trying to figure out our best strategy for providing that. And I think we've worked with the IT team and they've seen a way to be able from the New Heights system or New Hampshire Easy and they're going to produce a YouTube video for instruction to show how agencies can download their list on their own without having to, the department having to send a report. So we've been looking at our different ways of producing those lists so that agencies are more aware of it before we get to the end point. So that is.
So are you saying that today, if you go into New Hampshire Easy, your cases that are closed for medical review are listed as such?
No, I think what I'm talking about is your earlier request about being able to see a list of the people who are going into MEA review, so you are able to see before they get into the closure situation, the early on part of it.
Okay, thank you.
Right. Any other items that folks would like added to the agenda? I'm not seeing any hands, so as always, if you do think of things between now and next month, you can go ahead and email myself, Carolyn, in the department, and we can see if we can get them added. Depending on, how close to the meeting you request it, we may or may not be able to add it to the next meeting, depending on what the agenda already has for the following month. But if it's requested shortly after this meeting, usually we're able to try to fit it in. So next on the agenda is the adult dental quality strategy.
Hi, good morning. Thank you so much. Let me share my screen. All right, can folks see the PowerPoint?
Yes.
All right. Great. So thank you for fitting me into the agenda this morning. I don't plan to take up too much of your time today. I'm Erin Metcalf. I'm the administrator for the Medicaid Quality Program, and I'm here today to go briefly through some updates to New Hampshire's Managed Care Quality Strategy. All right, so most of you are probably familiar with the quality strategy. I'll describe it briefly. I'll go through the updates and we'll talk through where we're currently at and next steps. Oops. Okay. So the quality strategy, it's a comprehensive federally required document demonstrating how a state assesses and improves the quality of healthcare and services furnished by managed care organizations. It should be updated regularly, at least every 3 years, or when there is a significant program change, such as a new population or a new managed care contract. And so it's this requirement why we're here today. So if you recall, last April, New Hampshire began a new adult dental benefit. And it was added to the existing managed care program. Services are administered through a separate prepaid ambulatory health plan. So it's considered a significant change in a new population. So we've updated our quality strategy to incorporate the new adult dental benefit into existing goals and objectives where it's applicable. And CMS requires a public comment period and various stakeholder awareness and input, including MCAC. So that's why we're here today. The primary updates which align exactly with the applicable managed care topics include dental network adequacy, time and distance standards, dental provider network access to care, dental member experience of care and customer service surveys. dental contract compliance activities, dental performance measure validation activities, encounter data validation activities, performance improvement initiatives, and a dental liquidated damages program. So I'll just get into the specifics. I'll go through each one, and there'll be time for questions at the end. So under goal 2, which is assure that members have access to care and a quality experience of care, we have objective 2.1, which is to ensure that the MCO and dental provider networks meet 90% standards of time or distance for each New Hampshire county. And so specifically for the dental network, we will be assessing the percent of New Hampshire counties in which all dental provider networks, we only have one, but all dental provider networks assure that 90% of members meet the time or distance standards or have an exception request submitted to the department. The dental network is new. It continues to grow. It's evaluated regularly. So we expect to have a baseline shortly. And obviously we have a goal of 100% of New Hampshire counties meeting that standard. Also under goal 2, we have objective 2.3, which is ensure the MCO and dental organizations provide accurate information in their organization's provider directories. So specifically, we'll be evaluating the percentage of dental organization audited dental providers with exact matches between the dental data and the provider directories that they have available. This is an EQRO activity that they will be performing on our behalf. So baseline and targets are to be determined at this time. Also under goal 2, we have objectives 2.4 and 2.5. 2.4 is ensuring that by the end of state fiscal year 25, member survey results related to access of care are higher than the national average for Medicaid managed care health plans. And so there's an adult dental CAP survey similar to a CAP survey in the managed care world. And we've selected 3 access to care survey responses that we'll be looking to compare to the national average. Those are getting dental appointments as soon as they were wanted, getting appointments with a dental specialist as soon as it was wanted, and ease in getting emergency dental care appointments as soon as they were wanted. We also have objective 2.5 around customer service survey results, and we've selected 2 there. The dentist explained things in a way that were easy to understand, and the dentist treated member with courtesy and respect. So again, this activity will be performed for the first time, and we will then compare it to the national average. So we will have baseline results soon. All right, so switching to goal 3, which is assuring, I have an echo. Is that just me or can folks hear that echo too? Oh, maybe it's better. Okay, maybe it's good. Thank you, sorry. So goal 3, which is assuring managed care and dental contract compliance. Objective 3.1, demonstrate contract compliance and identify issues through ongoing system-wide performance measure evaluations. So specifically, we're looking at the percentage of months that DHHS evaluates dental performance standards and addresses them with Dr. Finney or Henry as necessary. And so this process has been ongoing since the beginning of the contract. We have simply rolled it into our existing managed care process. We expect it to continue. And objective 3.2 is related to another EQRO activity that we do separately for managed care and will also be doing for dental. The entire dental contract will be evaluated, I believe, next month against all 18 standardized contract compliance tools. So we do expect that the dental organization will meet all of those standards or have a corrective action plan approved. So that's what these 2 objectives are for. In goal 4, goal 4 is assuring the quality and validity of MCO and dental data. Objective 4.1 ensure that annual EQRO performance measure validation audit results verify the accuracy of MCO and dental performance measures. We do have a standalone Exhibit O specific to dental, which our EQRO will evaluate a selection of metrics from that Exhibit O to ensure quality and accuracy of performance data. Again, this is an ongoing activity being performed for the first time, and we anticipate 100% for that baseline. Also related to Goal 4, we have Objective 4.2, which is ensuring that monthly EQRO encounter data validation results demonstrate managed care and dental contract compliance for timeliness and accuracy of encounter data. We have various technical specifications we look at for our encounter data, member identification, billing provider information, validity of servicing provider information. We've inserted some baselines based on what we know about the managed care world. But again, this is an ongoing activity and we will update baselines accordingly if necessary. In Goal 5, Goal 5 is to maintain quality performance improvement initiatives. The dental organization is required to do PIPs just like the MCOs. The EQRO will validate those PIPs. This is an activity we are just beginning and we'll have a baseline shortly. We have a second objective, 5.2, which is ensuring the managed care organizations and dental organizations have acted upon each external quality review recommendation or finding. So every EQRO activity has an associated report, which typically includes recommendations for either the managed care organization or the dental organization. And DHHS has a process to monitor and follow up on those recommendations. And so this objective is explicitly expanding that follow-up process to the dental organization.
Erin, can you just explain what PIP is, just for people may not be familiar or don't remember what it stands for?
Yep, PIP is Performance Improvement Project, and they are selected based on our priority areas and our quality strategy, goals and objectives. And it's a kind of a three-way collaboration between our external quality review organization, DHHS, and the dental organization in this case.
Thank you.
Yep. All right, and also under Goal 5, maintaining quality performance improvement initiatives, we do have an objective 5.5, which is to maintain liquidated damages program that includes sanctions that are compliant with 42 CFR 438 Part I. As mentioned, we have expanded the director's remedy process to include dental and which may include liquidated damages if needed. This has also been ongoing since the beginning. So we are anticipating 100% baseline for this as well. So we are coming to the end of the open comment period. It was March 12th to this Friday, so there's another week. We did initiate public comment by posting the quality strategy draft, and we did email various stakeholders, including MCAC, several weeks ago. There is a link here. I believe the slide deck was attached, so you can you can find the entire document at that link. I'm happy to accept comments through our Medicaid quality email. Just reference any page number that you're referring to. And I believe there's a few minutes for questions, or if Dr. Finney has anything to chime in about.
I think the only thing, thank you, Erin, that was great. I think you can see, obviously, this is the first year. We have to gather a lot of baseline data during this initial year. So I think you'll see in the coming years, the reporting is going to be much more full. And, you know, we'll really start to see where we need to guide things. So it truly is a work in progress. We are meeting multiple times a week on just dental quality and making sure that we're really getting everything lined up accurately right here in the beginning so that we can move forward meaningfully. So I don't know if anyone has any questions or comments now.
Sir, how many people have been served?
We're actually up over 12,000 members have been served as of, the, claims and member counts that we got at the end of March. So those are increasing month over month significantly. I think we've got the ball rolling. The dental organization is still working very hard on recruitment. That has not eased up. And we have a meeting coming up later this week to really take a deep look at our mobile strategy so that we can make sure that that is also working as a very important part of our network.
Can you just elaborate for those that may not be, I know you've talked about this in other venues, just what is the mobile van that goes around and what it's equipped with?
Sure. The mobile unit, it's almost, it's not really a van. It is a semi. There are 2 full dental operatories. One on either end of the trailer. In the center is their sterilization area and their administrative area. They also, very fortunately, they can take x-rays. They have a panoramic radiograph on board, which is really important. They can do everything from cleanings, exams, and x-rays on up. Everything that's included in the benefit can be done in that mobile service. Our strategy to date has been to look at the areas of the state where we realize we're short on providers right now and getting to those areas so that we can begin to serve people. And the intention is to continue going back to those areas repeatedly. These are never meant to be one and done type visits. This is truly a part of our network. And so they are going to be going back to the same area over and over again. So until the rest of the network fills out, that could potentially be a dental home for some of our members. And so we're constantly looking at where the services are needed. We're always open to comments from any of you who are out there in the field. If you know of an area that is struggling or you have members that you are serving in other ways, please let us know, because we are trying to really use our contacts throughout the state to accurately determine where we need to bring the services.
Yes.
Yeah.
For the things as stakeholders that we can do to help support you find a home base for that mobile unit in those places?
Yes, absolutely, because obviously it's such a large unit. They have, Solvair has paperwork to sort of say what the minimum requirements are for locations. And we can share that. And Solvair is very open to conversations. We really try to step out of this and let Solvair work with different communities to find the right places. So yes, if you have suggestions or, you know, of an agency or an organization that, feels like they have, a pocket of individuals there that could be served, we want to hear about it.
And then if there are areas in the state that you need help finding a home for it to land in for a day or, repeated visits, we bring that to the committee so we can help
Absolutely.
provide that support.
I'm just curious, how is the truck staffed? Like, how do you find the people to
They Solvair handles that. So
Okay.
the hygienist assistants and dentists that work on there are New Hampshire licensed dentists. They're enrolled in New Hampshire Medicaid, and they work in other states. They have a lot of experience with this. And so they came in, and once they saw what the need was here, they were able to ramp up their staffing. So, I mean, they have the same issues that everyone else does. There has been some changeover, but I think there are certain individuals who are looking to practice in that type of a setting. And so, they are able to find those people, and it's working well so far.
Sarah, I have one small comment. I don't know how appropriate it is to quality or not, but we have had reports of consumers not being able to use the medical transportation to get to a dental appointment because the vendor isn't recognizing it as a medical appointment.
Because it's, okay, there's, a separate contact phone number for transportation related to dental appointments. And I would be happy to share that with all.
Well, that would be fabulous because I do not believe that is information that has been shared with us previously.
Okay, I apologize for that.
Well, I think all the case management agencies could use that information.
Okay,
Yeah, that's
Thank
great.
you.
I had no idea.
I will take care of that.
It's, the name of the vendor is,
It's CTS.
yeah,
Oh, it is, oh, it
has a
is
separate
CTS.
contract with Delta Dental to provide transportation.
So you can't call the regular CTS line, you have to call a dental CTS line?
I believe, yes, it is a
Okay.
dedicated phone number with CTS for dental. And,
Great.
okay, all right, I will get that over. I'll share it with Kristen and get it out to everyone.
Any other
Joe?
questions? Yeah.
Joan, did you let me?
Yes, I just had the question, is there any development along the lines of meeting the homebound population?
Sorry.
The homebound population, any developments there?
These are all things that we are working on in our network strategy. And so, that is ongoing, and I can't give you more of an update than that, but we realize that we need to work on all of the individuals that need care. And, we've been going through various parts of our population with special needs and trying to address them. And that's where I feel like year two, we're really, really digging into that to find the best way to serve those individuals.
Thank you.
Any other questions or comments? Right, well, thank you for that presentation. And now we'll move on to the legislative update.
Thank you.
Barry.
All right, so we are moving towards crossover at the end of this week, although a lot of bills have already started to move over into the other chamber. I'm gonna, assuming you guys are gonna want me to do this next month, I'm gonna significantly pare down our document to get rid of some of the bills that are no longer being considered. But we'll start on page 1 with HB 1010. This was relative to expanding maternity options and midwifery access. This was put into interim study. There was quite a bit of concern by providers about the safety of this bill. Moving to HB 1028, relative to the definition of mental illness for purposes of the New Hampshire Mental Health Services System. That has moved over to Senate HHS. There was a public hearing on 4/3. I'm not sure if anybody attended that. I didn't get a chance to review that, but that is moved over to the Senate. Moving to page 2, HB 1245, that is relative to the release of confidential records of a person appointed a guardian. And this is in Senate Judiciary. At this point in time, no public hearing has been scheduled. Moving to page 3, HB 1571, that's relative to requiring insurance coverage for glucose monitoring devices for people with diabetes. That was put into interim study and has not made it over to the Senate. I don't expect it will. HB 1604, relative to the use of electronic medical records. I noticed that I thought I updated the status on this, but I had not, or I did and I didn't save it. But that is currently before Senate HHS. There was a public hearing on 3/27, where the department had testified that there were some concerns about how it would affect our operations, given that we have several other statutes and federal requirements out there relative to the requirements of using electronic medical records. So we spoke with the sponsor of that bill, noted our concerns, and he was fine with an amendment. So I'm working with the committee and the insurance department on amending that bill to address our concerns. So that'll, stay tuned on that one. HB 1616, relative to parental consent for student participation in Medicaid to Schools program, that has moved over to Senate HHS. No public hearing is scheduled at this point in time. HB 1660, relative to coverage of certain procedures for minor children under the state's Medicaid program. This is to ban gender transition surgery for minors in Medicaid. That's currently before Senate HHS. No public hearing is scheduled at this point in time. On page 4 or 5 here. Okay. So page 4, top of page 4, HB 1663, relative to the confidentiality of medical records and patient information. This was a bill that the department testified on to expressing concerns about the effect on department operations. That was put into interim study as of 3/6/24 and remains there. HB 1683, relative to coverage of circumcision under the state Medicaid plan. This has been laid on the table in front of the House. This has actually had some very interesting procedural issues. If you have a chance to watch that, it was a bill that the House couldn't decide what they wanted to do with it. They moved to pass it, which failed, and they moved to kill it, which failed, and they put it back on the table. And this has happened twice. So they don't really know what they want to do with that bill. I expect it'll probably die on the table, but we'll see. HB 1689, relative to the use of personal identifying information by state agencies. That was also put in an interim study in February. HB 1702, relative to oversight of Liquor Commission funding and repealing the Liquor Commission fund. This was a bill that had some major effects on Granite Advantage. We expressed those concerns. The committee decided to put it in an interim study, and I expect it will not be picked up again until, actually, I guess we'll die because at the end of this session, it's a new session. But HB 1706, relative to notice required prior to circumcision procedures. That was also put in an interim study on March 7th, 2024. As moving down to the bottom of page 4, SB 312, relative to third-party liability in Medicaid. This was a department requested bill to update some of the definitions. That is now before House Commerce and Consumer Affairs. No public hearing is scheduled yet. Moving to page 5, SB 337, relative to doula and lactation service provider certification. This was also department requested legislation. There was a public hearing held in front of House ED&A on 4/3/24. The bill had been amended by the Senate to specify some of the entities that could license and certify providers. But an amendment has been introduced by the sponsor to remove those specific bodies from the legislation. So now it's back to just a generic process, or at least we expect it'll go back to a generic process if they adopt the amendment. There's a work session scheduled for that, or pending to be scheduled in the near future. So we'll be following that one, and we'll probably be testifying.
Rob, can I just add a clarification there? The reason it was requested as a technical amendment by the department is that when they combine Senate Bill 175 into HB 2, they required rulemaking in a particular section, but then left out creating the section in which it went to go to, and that was why we requested it, so that we could actually implement what was in HB 2.
Yeah, so that was originally part of the omnibus bill from last year. When they laid that on the table, they moved it into HB 2, but they forgot this provision. So it was a simple mistake, but a big mistake, I guess, in terms of our ability to implement the program. So which is why we requested. Thank you, Henry. Moving on to SB 401, which was repealing the prospective repeal of the Granite Advantage program. That was put into interim study on March 7th. SB 403, well, it's relative to healthcare workforce investments. That is before House HHS and Elderly Affairs. The public hearing is scheduled for Wednesday on that bill. SB 407, relative to direct pay for ambulance services. Right now, it's still within before the Senate. Committee report is out to pass as amended. I expect the Senate will take that up before the end of the week to determine its ultimate fate, whether it will go to the House. SB 409, relative to reimbursement for ambulance services under the state Medicaid plan. That is before House Health and Human Services and Elderly Affairs. Public hearing is scheduled for this Wednesday. SB 455, relative to Medicaid reimbursement rates for prosthetic or orthotic devices. That's still before the Senate, but it was passed. There's a waiting crossover to the House. And moving on to page 6, SB 497, relative to establishing the disproportionate share hospital fund. That was amended by House Ways and Means to address a concern they have with some language, but that has been recommended opt to pass by the committee. It's on the consent calendar for the full House. We expect that to be passed and move on to, I guess, the governor's desk for signature, unless it goes to the Finance Committee. It actually probably will go to Finance because it's got a fiscal note. SB 554, relative to Medicaid provider enrollment licensure for verification. This is before House Health and Human Services and Elderly Affairs. And finally, SB 555, relative to receipt of pharmaceutical rebates by insurers and pharmacy benefit managers. This is before House Commerce and Consumer Affairs. We had testified about some concerns relative to its effect on the department. We requested some language to amend it to remove Medicaid and the Ryan White program from being affected by this bill, and that language was implemented. So we are neutral on that at this point. And I'm happy to take any questions.
Thank you, Rob.
On the agenda at the end of continuous coverage requirement, Medicaid unwind.
Dave's going to lead us this morning.
Good morning. Let me share my screen real quick with the unwind data. So I'll jump down to slide 4, and
Dave,
in
can
the
you
chat.
please slides?
Yep. Is that better?
Yes, thank you.
And in the chat after the presentation, I'll drop in a link to the CMS data. I think when we printed the slide deck to PDF, the hyperlink got stripped out. But so CMS has been collecting renewal data from states since the start of the unwind. And so this month we thought maybe we'd show some of the other states and the data that CMS has been collecting. So for the month of January, these are CMS's preliminary numbers for the renewal analysis for all 50 states. And so in this chart, you'll see New Hampshire is here at the top in the first row. And then we listed out the other New England states. And then in the bottom in the orange is all states. And so New Hampshire exceeds the national averages in the percent retaining coverage, which is shown in this column here. And you can see New Hampshire is around 91%. The nation on average is 62%. And then the other New England states are generally 60 to 70%. Maine's in a bit of a unique position because they actually just started their unwind process more recently. So the data for them is a little different. Ex parte rate, New Hampshire had the 4th highest ex parte rate in the nation at 81% for January. And that's shown in this column here. The percent terminated for a procedural reason, New Hampshire was 8% lower than the national average. And you can see that in this column here. And the percent pending at the end of the month, New Hampshire had 3.3% applications pending at the end of the month, which is 15% lower than the national average. You can see that over here. The state also had the 9th lowest closure rate for the month of January. And for the pending applications, it was 11th. But a couple states in the top 10 had 0%. Massachusetts, just a little unique. And then on the next slide here, this is the numbers for December. And it's a similar story. Percent renewed in New Hampshire was around 83%, 62% nationally. Ex parte rate was similarly high, 75% versus 47% nationally. And the procedural termination was also lower than the national average. At New Hampshire is 9.1%, and the national average was 13%. And this just shows our ex parte rate trend by month. So for May, we were at 77%. It's been over 70% now since November. So it continues to remain high. And we're still relying on a number of the CMS flexibilities for the E14 authorities that allow us to get a bit higher of an ex parte rate and more efficient processing.
David, can you speak, or Dawn, can you speak to the latest one we're asking for?
The latest E14?
Yes.
So the latest E14 authority that we have requested to CMS is to allow us to do more ex parte renewals with the asset limit up to $2,500 or below.
Up from a thousand.
Up from, it's increasing, we're actually increasing it from 1,000 to the 2,500.
We expect to be able to implement that in May.
We have put the system changes in for May readings. So in May, hopefully we'll start seeing more of those going through.
And this is our standard point in time enrollment dashboard.
That one needs to get a little bigger too.
Okay.
There you go.
And so at the beginning of this month, April 1st, we were at 82,753. And we've seen this number tick up incrementally since about November, where we had roughly 179,000 enrollees. And on the next slide, you'll see we broke it down, tracking it from November to see where the increases were and how the population's changed. But it's mostly been in this adult expansion, Granite Advantage, and low-income children. Make this one a little smaller. And so this is the point in time change. So we looked at early November to see where the enrollee increases came from and which population categories they fell into. So there was a large portion in the Granite Advantage, which is this brown line here, and then low-income children, which is this yellow one and this purple one. And it's interesting. So I mean, in effective October 1st, we had 12 months continuous coverage for postpartum women, and then January 1st, 12 months continuous coverage for children and legally residing. And for the low-income children, you can see a pretty sharp increase here, which is right around January 1st. And so there's been an increase in enrollment for low-income kids around 1,500 and 1,000, so 2,500.
Kelly, you have a question?
Yep.
Yeah, I have a question on your last slide, David. Do those numbers surprise you, or are they in line with what you anticipated? The trends here.
I think for the children, they're in line with what we anticipated. There was actually a recent CMS report that projected out children and CHIP enrollment for states based off of the new 12 months continuous coverage obligation that went into effect on January 1st.
Exactly.
And it was showing New Hampshire as having a 7% increase for a full year.
So I would have expected the same thing. How about the adults? The Granite Advantage.
Yeah, I think part of this is attributed to the 12 months postpartum coverage. I think when we first saw this, it seemed maybe a little higher than expected at the 2,600 number. But Henry, I don't know if you have any other thoughts on that aspect of it.
So I think one of the increasing trends we've seen is people using granted advantage when they have a disability that is waiting for some formal certification. And so I think that's one thing that we believe to be the case. It's sort of counterintuitive to the economic trends. But I think that's what's going on there. And also, I'd like, before we leave this slide, Dave, we just comment on the ones that are on the line and below the line.
Yep, so below the line, this pink line here, we've got low-income non-disabled adults, which is a decrease of 972. And then adults with disabilities was minus 209. And the rest seem to stay pretty close to neutral.
Which are, can you just read them out?
Yeah, they're elderly with disabilities, foster care and adoption subsidy, and children with disabilities.
Thank you.
Carolyn has.
David, given the demographics of our aging population in New Hampshire, what do you attribute that decrease to for the elderly and elderly with disability?
So it looks like the elderly and elderly with disabilities is minus 72.
Yes,
So what is the attribution is the question is.
it's contrary to our demographic data and several other things, so it should be an up number, not a down number. And in addition to demographics, any projections that the department has made for various programs, it has that number climbing. So what's failing there? Something's failing.
I think we're trying to, obviously, the questions that have been raised around MEAs, we're doing the deep dive on that. In terms of the actual redeterminations, I think we'll have a slide on that. There are, Deb Fournier just got us some demographic information, which we haven't had a chance to sort of look at. One theory to test out, or one issue, is the economic standing of New Hampshire and individuals. We've seen that in another category, but we haven't finished that analysis. We were focusing, primarily on, zeroing in on people we can help that have not, that have been brought to our attention. That's been our focus. But we have done a little work with, but I think hopefully by next month we'll have more insight into that.
Yeah, it's concerning, and I know with the younger population, the economics of their situation may be increasing. I don't believe that's true of the.
So I think to be fair, I don't think we have a full accounting yet of that, and I do think that we, it is we're putting a lot of time in trying to get into behind that.
Thank you.
No problem.
And if you have extraordinary cases, as
I'm not talking about individuals.
No. I'm just saying that those we're still learning, if you will, from the cases that have been referred to us.
Thank you.
I think we're ready for the next one, Dave.
Okay. And this is the CMS reporting and closures cumulative slide, broken down into the protected and non-protected. And it's from March 2023 through the end of last month, March 2024. The middle column is the protected population. There haven't been many changes since the last month's slide on this, just because we're really in the tail of the unwind. And there, you can see here, there's 37 in progress. And we can look into
and can you make this one better too?
Yep. And this is the same look, but just for March. So you can see there were 29 renewals for the protected population in March, just over almost 11,000 in the non-protected population. 91% of the non-protected retained coverage, 88.5 or 23 individuals retained coverage in the protected population. And then similar in February, 94% of the non-protected retained coverage, 92.4% in the protected population retained coverage, but again, much smaller numbers in the protected population just based off of where we are in the unwind. And this is the full look at the dashboard for the protected population. So you can see it's broken down by month and the open and closing results for that. And so we only have 31 individuals left in the protected population to go through a unwind READY. And this is the same look, but by percentages. And this is the same look for the protected children population by percentages. And long-term care and disabled. And so you can see all the redeterminations left in the unwind population are all in the long-term care disabled group. And this is for the CFI population, and it's a mix of protected and non-protected dashboard. And this is cumulative through June to March. And we have a further breakdown in the later slides that just show the results for March. And we have that I can jump to those. We have those by nursing facility, CFI, and long-term care generally. So for the month of March, there were almost 1,100 redeterminations in the long-term care group, 12 closures and 1,063 retained coverage. And a lot of that, there was a high passive renewal. So 810 of those were ex parte, which is about 75%. And this is the same slide by percentage. And then this is a look at the HCPC subpopulation. So there was 8 closures and 789 individuals retained coverage for the month of March. And a pretty high ex parte rate, right around 81%. This is the same look, but by percentages. And this is a further breakdown for CFI. So 337 completed redetermination and retained coverage, 5 closed, and an ex parte rate of about 76%. And this is the same look for CFI, but by percentage. And then this is the dashboard for nursing facilities. So there were 4 closures and 274 completed redeterminations and retained coverage. And an ex parte rate for this population was 57%.
There's a question in the chat. Do the closure numbers reflect anyone who is appealing closure?
Yes, so it's the closure, but if someone's appealed, the closure they'd still show up in the closure report or the closure reasoning. And then if they had requested a continuance of their coverage, they would be open pending the appeal. but they would show up as in the closed data.
Any other questions?
Just, after. one more comment.
And this is just our call center metrics and the data that's submitted to CMS.
David, I guess the other thing I just lift up for we don't have a slide deck on, but, you know, I think a couple of meetings ago or one meeting ago, we had, discussions with the community mental health centers. And, so we asked for them to provide us, data from their end, and we've done some mining on that and just provided them feedback on that
Feel free to do it.
Whoever, there's somebody speaking, if you could please mute, that would be great.
I muted the participant.
Thank you.
So what we were able to do is divide out by closure reasons, and then they've asked for some additional detail on that. We're working with them. I think 6 centers gave us information. I think of the people that closed, a third of them, 33% were income related. But we also found that 500 I think it was about 2,600, 2,400 cases they gave us, David, that 500 had reopened since. But we're continuing to work with the community mental health centers as we're also trying to do a deep dive on the CFI and MEA issues. And I guess we're working also too on with Deb Fournier on lifting up special enrollment periods. I think since we last met, the Medicaid special enrollment period has been extended from July until November, meaning that people who lose Medicaid coverage who want to apply for exchange coverage don't have to wait for new open enrollment. And then on the Medicare side, we want to continue to lift that special enrollment period up. So we're going to put together a program on that with the insurance and the navigators. And one of the questions the navigators asked us to look into with the feds, which we did, was that with federal poverty limit guidelines changing in this month, with whether people who are on exchange who otherwise could be eligible for Medicaid, is there an automatic way that they get notified? Unfortunately, there's not, but that's, I think, one of the other things we'll want to look up is, you know, if exchange coverage is good, but for people who are low income, Medicaid offers lower cost sharing and broader coverage. So we'll want to make sure that people are aware of that. So those are things that we're working on as well.
I have a question about that, Henry. I hadn't heard that the poverty level was changing, so thank you for sharing.
March. We increased our FPLs in March.
So they're effective in April, though?
They're effective March 1st.
Okay, I hadn't heard that. I do have a question.
Every March.
Does that, that's a lot to keep track of, It's at the top of my list, but thank you for bringing it up. Does that change the QMBs from the, whatever we're calling those Medicare members?
Yeah.
So do we have people that were closed off of those programs in December, January, February, who would now qualify? And what are we doing about that? Re-qualify.
They could potentially.
So what do we
They
do?
would probably have to reapply. I'll double check, but I don't think we actively look for people who had closed.
Because we had a number of them.
Yeah, we also have an issue that we're still waiting for
Yeah.
CMS to get back to us on to help. There's about 139 people that we've been waiting.
I think those are the people I'm talking to.
Yeah, we've been, when I went down to Baltimore, I raised it and we've been trying to
Sent
get,
them a couple emails.
we're trying to get an answer on that issue. We told them people have been waiting a long time on it.
Okay, thank you.
We haven't forgotten that.
All right, so someone will get something out about the impact of the March change for us?
Yes, what
Thank you.
specifically would you like to know? How many people switched from potentials?
Why don't we take it back?
I'd like to know it all, Don.
Oh.
Yeah, the other thing that we're looking at too is, for people who are in and out Medicaid, who potentially could be in the
135.
130, could be 135 group that, what we can do to keep them on, even when they're coming off and on with respect to that would be benefits. So that's another thing we're working with CMS on to try to help people, even though their medical's going off and on.
Yeah,
We can do
yeah.
to keep them constant on the Quimby during that whole time. So we think there's a state plan amendment opportunity there, and that's what we're following up with CMS on that too.
So I have a follow-up on that then. So for the people that have lost CFI because they've been switched to in and out, if people are on the 135, can they be on CFI?
David, you know that one, don't you?
Carolyn, are you asking if someone could qualify for SLIMB 135 and CFI at the
Yes.
same time? So one of the conditions of eligibility for SLIMB 135 is that you're not eligible or enrolled in Medicaid. So if they were in CFI, they wouldn't be able to have the SLIMB 135 at the same time.
But if they lose CFI and subsequently Medicaid, and they become eligible under 135 and have Medicaid again, can they go back on CFI, or would that put them off of 135?
It would put them off 135. Being enrolled in SLIMB 135 wouldn't be a barrier to coverage under Medicaid or CFI.
Thank you,
We're still working those set of issues best we can.
thank you.
And Karen Rosenberg asked about sending out updated income eligibility requirements related to the new federal poverty levels. And I think we will be sending those out, Karen. I say we, I mean the department.
Yes. Collectively.
Yes, the collective we.
You got that?
Kelly,
Thank you. I'm sure you answered this, but if you have a little grace with me, my brain needs to hear it again. So people who have a spend down, and now that spend down would be adjusted potentially based on this change. Does that happen automatically, or would it happen when they do a read or when they contact you to say, my income's this, but your standard is now this?
So when the FPLs increase, what we do is the system, if you will, New Hampshire, New Heights runs what we call mass change. And it will redetermine everybody's eligibility based on the new FPL. So if you are currently SLIMB 135, but it puts you into SLIMB 120, you'll be moved to 120. Does that make sense?
But you're on mute.
You're on mute.
You're on mute.
Follow up, so it would adjust them to a correct program that they may qualify for. That's a lot for us to be aware of, so that's important to hear. Thank you. And does it do the same thing in terms of what their spend down amount would be? Let's just say my spend down had been $100, but based on the new income standard, it would be $80. Does that change through a mass adjustment in your system as well?
Kelly, I have to take that back because the income standard for spend down is not really tied to the FPL.
Okay.
But I want to take it back, just to confirm.
Okay. Thank you very much.
Yeah.
any other questions? So with that, we can move on to HE 805 rule. E-2 data factor.
Hi, Brian Clark, General Counsel.
Brian, why don't you move down so they can make sure you can sit in one of those chairs, but I just want to make sure they can hear you well.
Hi, can everyone hear me okay? Okay, Brian Clark, I'm General Counsel for the Bureau of Elderly and Adult Services. So I'm here today to talk a little bit about what changes we're proposing to the HE 805 targeted case management rule. And then I'll open for questions and any other feedback people might have for the department. So the department is proposing making several changes to the HE 805 rule. Specifically, where in the definition section 80502, we're aligning certain definitions with the recently updated HE 801 rule. And we're also adding definitions for telehealth and transitional case management. With the 80503 eligibility section of the rule, we're just updating it to remove an erroneous reference to a state law that does not apply. For the provider agency requirements, we're removing the requirement that case management employees be screened against the registry for child abuse. And we're also adding in a requirement that case management agencies shall accept or deny assignments within 3 working days of notification of assignment. We're also adding a requirement that case management agencies in the comprehensive care plan, whether a participant chooses to receive services via telehealth. We're amending the required case management services section to allow delays in comprehensive assessment if the participant or the participant's guardian or power of attorney request it. We're also amending it to include in that assessment whether the participant chooses to receive services via telehealth and whether the participant has any opportunities to direct their own services, participate in participant directed and managed services. We're amending the frequency at which face-to-face contacts are required to 90 days. And we're amending it to allow case management agencies to make contact with participants via the participant's preferred method of communication. We're amending 80507, the participant selection of case management agencies, to say that case management agencies may coordinate with mental health and developmental disability services, but only if the participant requests that case management agency to do so. They won't be presumptively the lead. The 80510 quality management section was amended to require that case management agencies provide Bs with completed quarterly quality management reports within 30 days of the end of the quarter, and that they provide BAS with a quality improvement plan if there are any deficiencies that result from an annual monitoring visit. The department is also adding a few sections to the rule. The department is proposing a waiver section to allow process for case management agencies to request waivers to the rule, so long as it's within the goals of protecting everyone's health and safety. We also added a section about transitional case management, which is a service for providing case management services for people in a institutional setting looking to transfer to a more community-based setting. Then we're also proposing 805.13. That's discharge section, and that's specifically just requiring case management agencies to notify BEAS of a discharge. And then there's the last section, HE 805.14. That's the telehealth section that outlines the expectation of case management agencies to document as part of the comprehensive assessment whether the participant chooses to receive any CFI services via telehealth, and whether certain basic requirements are met, such as having access to the technology and the internet, and to document that that assessment was made in their plan. And that is it for the changes in the proposed new sections. So I'm open to any feedback.
Hands up.
Well, we will take feedback from members first and then from non-members. Kelly is.
Mine isn't feedback, but I'm gonna just ask a quick sort of repeat of the element requiring case management entities to coordinate with mental health agencies if requested by the applicant or representative. But can you just repeat what that change is for me?
Sure. Let me get into the rule text for you. So 805.07, the participant selection of case management agency, previously said the participant shall be informed that the case management manager selected will also coordinate mental health and developmental disability services if the participant, or if such services are needed by the participant. And we're changing that to just say the participant shall be informed by the case manager selected that they can coordinate mental health and developmental services if the participant requests the case manager to do so.
Thank you very much. That's exactly the language I was looking to be sure of, that it was not an opt-in, but it was an opt-out. And it kind of is. When you say that participants shall be informed by the case management entity that they can do it, at least gives
Right.
them the opportunity to say thanks, but no thanks.
Yes, that's what we're looking for.
On that same section, Brian, how do you see the case manager coordinating and authorizing mental health and DP services?
So it's about coordinating CFI services around the delivery of mental health services, not coordinating those services specifically.
I think that could be clear.
Kara?
Hi, thank you. Kara Nicholas from Cratchit Mountain Community Care. I just want to make some comments and express some concerns, particularly around the 805.14, which is the addition of case managers assessing for the appropriateness of telehealth delivery. First comments I have are on a couple definitions related. In the definitions section of the proposed rule, the definition of telehealth states it's a real-time interactive communication between a patient and physician medical provider. Later on in the 805.14, it talks about if the participant chooses to receive any services. I think that needs some clarification so it's consistent exactly which services are intended for this. Another definition related comment that I have is around in the 805.14, it talks about the conferencing provider. the conferencing provider is not defined in the definition section. And I just think that with that left open, it just leaves people to assume what that is and could cause some confusion. I want to just comment that I don't think that it's appropriate for case managers to be determining if a service can be effectively delivered via telehealth. Each individual provider should be doing that. For a good example is nursing visits. An RN should be determining which modality would be most appropriate to deliver home nursing assessments and ongoing monitoring, and whether telehealth should be considered for that. I think this would put case managers in a position of making a clinical decision that they're not licensed to do. And as a director in a case management agency, I feel like that puts some inappropriate liability on our agency when we're doing that. I also wanted to just point out CFI authorizations for particular services, depending on an individual situation, can be authorized for up to a year. And the appropriateness of the services being delivered through telehealth could change on a daily, weekly, or monthly basis, depending on a person's needs. I think the individual provider agencies should be deciding at each time that they deliver a service, whether or not telehealth is an appropriate way to deliver that service. And then the final comment that I have is I think the underlying principle of telehealth is that the service provided is the same service that would be delivered if it was rendered in person. The services can be provided in a different modality, but it can't be a different service. And I think only the individual service provider should be responsible for determining whether or not telehealth could be delivered in a way that they're able to meet that standard. Thank you.
Thank you, Kara.
Thank you, Kara.
Are there other hands raised? I can't tell.
Lisa Adams had her hand raised.
Yeah.
One more.
Okay, Lisa, go ahead.
Hi, this is Lisa. Actually, I just want to just echo everything that Kara said. My hand was raised to say the same thing. The nursing agencies, I think, should be the ones making those decisions, not the case management system. As you know, especially with skilled nursing visits, they would be the most appropriate entity to make those decisions. Thank you.
Thank you, Lisa.
Are we allowed to speak here too?
Yeah, I was just taking members first.
Marissa Bird has.
And she's a non-member, is that correct?
Are there any members who are
Yeah,
on the Teams call that haven't been recognized?
I am a member. This is Marissa
Okay,
Bird.
Yep.
Thank you.
Yeah, we got your comment. What
Okay,
are the-
thank you.
What are the formal comment period dates?
The rule hasn't been filed yet, so the comment period hasn't been established yet.
I would like to yield my time to any non-members that have come forward to speak and speak only if time allows at the end. And I will be making a motion for a subcommittee at the end.
Seeing any other hands raised from members, so non-members who would like to comment?
I'd like to comment, I think,
Could you just identify?
oh, yes, I'm sorry, I'm Madeline Ulrich from New Hampshire Care Collaborative. And we have a Choices for Independence program, and I, echo everything that Cara said. I think, also, I have some liability concerns as an agency. I have, even more so than that, I have participant concerns, and for their health, as well. And, I'm just not sure. I guess, Brian, can you speak to which providers are we talking about? Are we talking about nursing? Are we talking about home health aides? PCSPs, I think adult day is in there.
So the intent is to do a a basic assessment of whether telehealth is possible and that the participant has requested it, that they have a device, that they have internet, and leave the actual assessment of whether it's appropriate to the conferencing provider, which I will add a definition of, that is a provider providing via telehealth services. I will definitely make a change to clarify that.
Yeah, I wasn't sure which providers we're speaking of. Certainly, if we have a PCSP that needs to go in there and cook and clean, they won't be able to do that via telehealth. We all know, we all know folks, my own grandmother would have been, oh yeah, I'm fine over the telehealth, if she could even get on it, right? Then the other thing I had on here, it says, the participant has a location to participate in telehealth. That means it meets the particular privacy expectations and a place to store devices when not in use. I'm just not really clear about that either. Are the staff supposed to find where they're going to put their laptops? I'm not clear about that number, what we're supposed to do in that.
Okay, I think the idea is to make sure that the participants' expectations are met so that they either are able to participate in their own bedroom or someplace that's private and not have to use like a family computer in their living room with other people they're living with potentially walking by. But I can be more clear about what the expectation is.
It's what I think I'm understanding from the response to this question. The intent of the section of the rule was for the case manager to have that threshold issue of is telehealth, if the clinician finds it appropriate and opts for this individual, which is part of, I think, right, of like, is there a private place that this individual can have? Because the provider who may say, this could be a service that would be appropriate to deliver via telehealth is not going to necessarily know if I have a space that is private in my living area away from other members. So is this supposed to be sort of empowering the individual to have this avenue available to them? And sort of an equity issue, right? Make sure that this population is entitled to have this care delivery model, which is becoming more and more popular, but they may not necessarily know the home environment or the person's individual limitations of, maybe I say I can get on my phone, but I really won't be able to individually. And that's where the role of the case manager is to sort of pick up that section. Is that what the intent of this is?
Yes.
Yes.
Oh,
See, nodding from-
I can also respond. Yes, in part, that's really what it is about. Currently in the rules, there is language that talks about the case management agencies being required to assess the services are adequate and appropriate. So that's really where that's deriving from. And ultimately, even if a provider of skilled nursing, for example, said telehealth is appropriate for this person, the participant still has the choice not to participate in telehealth and see somebody in person. So we want to make sure that those choices are being addressed in the comprehensive care plan.
That's great. Thank you.
I think the underlying issue with the telehealth is all of our telehealth statutes that are on the books put the onus in the provider to decide the modality. And there should be no reason why a case manager would have a responsibility to direct a modality choice for another enrolled provider on equal par. So, a home care nurse is an enrolled provider, just like a CFI agency. Why would the CFI agency be able to, or should it be reasonable for us to up or down another provider's choice of modality? Furthermore, why should it be up to the case manager to say, to someone, and I will say we have a lot of these situations, especially with some of the immigrant populations where how they live is in a room with 6 people. And they would be highly offended if you were to say to them, well, you can't have telehealth because we don't want your 5 family members there. The whole underlying principles laid out here do not demonstrate an understanding of the situations we are walking into. You're welcome.
Yes, Cheryl Fry from New Hampshire Care Collaborative. I have a concern, and comment to make about, section 805.04D, which has to do with the provider agency requirements and, acceptance of assignments. I wanted to consider adding another line to that. At the bottom, it talks about the reasons for accepting assignments or not. I would like to add something along the line of, or there is an imminent threat or danger to a case manager or case management agency based on historical evidence. So that's something that I would like to consider going forward to add to that.
Can you give an example just so we understand what you're trying to get at?
If there's a participant that's been threatening or has actually done something to a case manager, in a negative sense, and it's been harmful, a threat to their life or a use of a gun or other weapon type of thing. Those are the kinds of things that I'm talking about that have historical evidence to it. That I would like to consider adding that to this. Harm to a case manager or agency.
As a reason why you need more time then?
Why an agency can not accept.
Okay.
As a follow-up to that, this is the only rule on the books in the state of New Hampshire or law that says a provider must accept an assignment. And we don't do that to anyone else but case management.
And the liability is huge on that, so, I really like it to be considered and,
Having been,
that's all, yes.
we have Kathy next and then I'll to you.
Yeah, I was confused when I read this. I'm confused a lot when I read things that you guys send me, but what, why is it my social worker's problem to figure out if, isn't that between me and my provider if we do telehealth? I think that's the same question that Carolyn had, but I really don't understand what my social worker or anybody else except me and my doctor or respected whoever has to do with whether I receive telehealth. I don't get that. Am I supposed to call up the social worker and say, can I have telehealth with my doctor? Isn't that up to my doctor and me? It should be. I don't get it.
That was the question. May I rephrase that, Kathy? She's asking, she would have to call a CFI case manager to decide telehealth on a service where she doesn't have to call her doctor her social worker to decide if she can have telehealth with her doctor. It's a client choice and rights issue. You're assuming that the client doesn't know. Sorry.
So just,
I mean,
like,
cause I had telehealth before and I never called you up, Carolyn, and said, oh,
That's
Carolyn,
true.
is it okay?
Agreed.
Right?
So-
I don't get it. I don't get a lot of things in this thing. But
I'm with you.
So I just brought a hypothetical here in terms of accepting that what Kathy talked about, that doctors recommending a telehealth and, do you see
in
where?
my case, it would be me recommending a telehealth to my doctor because maybe it's like not good weather or I can't get there that day or she doesn't have a lot of time, so can we at least do telehealth? You know, something like that. It might be me recommending it to my doctor and then my doctor agreeing. So am I supposed to call Karen first? That's just dumb, I'm sorry.
So I was
I mean-
thinking about from where you exercised your self-determination that you want to have a telehealth visit. The case manager is aware of, as Brooke was talking about earlier, factors that might affect whether, what you want will actually be delivered, right? Or, one instance is if you have discussed it, but there's a privacy concern, they may want to raise that up. They may need some help in communicating with their provider that they need some help on the privacy side, or they may need some help on the technology side. I think what you're differentiating is between the clinical determination that's the appropriate modality, which I understand what your point is there.
And the provider is
Right.
responsible for the privacy concerns.
Because I've had telehealth before and I haven't called Carolyn and I'm not ever going to do that. I don't care what the rule is unless there's a reason I need to tell her how I'm feeling or something. I mean, cause I mean,
No.
you know,
However, yeah,
it's just dumb.
computers, anything. So why is that responsibility added here? You're gonna start covering that?
So I guess what might be a scenario, right, is where you might need to bring to the department's attention that we need to help them on the tool side, or it might be a situation where.
Well, with all due
I
respect,
finished my thought. So the other scenario could be, is that, someone feels like the provider may be pushing the CFI beneficiary to have telehealth, and they may have difficulty in communicating with their provider and sort of pushing back. They may need some support in doing that. That could be another scenario where, I think you've raised some good points here that need to be taken back and worked on. But I think there are some scenarios where you do help people with different situations, and that might, I think the telehealth responsibility is of the provider, as you talked about, in terms of determining it. But if the person is not, have circumstances around that they need some help in talking to the provider, just like, you help them with a redetermination, right? You might help them.
well, we do that,
Yeah.
Henry. That's part of what we do anyway, covered elsewhere in the rule. This is saying that you, the case manager, has to make a decision on this individual's telehealth with a provider that you're not responsible for, and sign your name in blood and send it to the department. There's a form required.
So I think we're in the process of proposal and understanding what the concerns are. I think we've I think I understand the concern raised, so I think Melissa Hardy wants to get a.
Yeah, I think, thank you for the feedback. I think we're looking at kind of two different issues within telehealth, right? I think environmentally, is somebody set up, whether it's technology, whether it's internet, whether it's privacy to participate in telehealth services versus the clinical determination by the provider if the service is appropriate to be provided by telehealth. I think somebody said something about home health care or a PCSP. I mean, you know, that would be pretty difficult to be provided via telehealth. So I think we need to iron out those details under this, because I think they're distinctive.
Follow up, while I agree about the internet, the phone, the computer, we have no resources to assist a consumer with access to any of that. So if that's what you're really looking to solve here, create the service, telehealth access and equipment or whatever, and put the service in, and then we have something to work with. What you can't do is say, make sure they have a computer and a phone and internet access, when there's no way to cover that. Oh, and Wendy is a hand.
And people, most people, excuse me, I just made my hand. Most people, if they even suggest telehealth, they know that they're capable of doing it. Like, you know, they know they have equipment. They can explain how to have people hanging around. But like, you know, my family pops in whenever. And so you know, I'm not, nothing's gonna be perfect ever. And that's just life. And I don't know, and none of this seems realistic to me. And I'm just happy, but it doesn't seem realistic.
We've got lots of folks with hands up, so I'm gonna ask that folks can just wait to be recognized before speaking. Wendy, you wanted to?
I just want to make sure there weren't any members you wanted to address first.
Yeah, we've got,
We've Joan.
yeah, we've got, is it, I don't know if it's Kara or Kara, but you're first on the list.
It's Kara. Just, I'll be very quick. Carolyn was referring to a form we would have to fill out as part of the assessment, and I believe, Carolyn, I'm assuming that you're talking about the telehealth checklist.
Doesn't the rule refer to a form, Kara?
Yeah, it's the I believe it's a telehealth checklist that I know was distributed, which is form 3760. And just for example, the first question is, does the participant feel that participation in telehealth meets their service needs and goals? And on the face, that might not sound real clinical, but if I would not want as a case manager to have that conversation with somebody, because I don't necessarily know what telehealth is going to look like when it's delivered particular to a service. If I was an individual being served, I would have questions. And I don't think that the case manager is going to be the best person to be able to answer what's that service going to look like, so that the participant can make a decision whether or not they're comfortable and they feel that telehealth would meet their goals. That's all.
Thank you, Kara.
I just want to do a time check, Henry, to see if you've got time to cover the rest of the stuff in the agenda.
And I think the rest of it can move pretty quick.
Okay, so Karen, go ahead.
Thanks. Just regarding the suggestion about giving a basis for denial of case management services to an individual alleged for dangerousness, I think that if the department is inclined to do that, there ought to also be due process, which would mean giving the person or their representative a written decision, including the basis for that decision and an opportunity for the participant or potential participant to have a fair hearing on the issue to make sure that such determinations aren't arbitrary or they're not due to behaviors that are manifestation of the person's disability that could be mitigated through various accommodations or services.
Thank you, Karen. Joan, you had a.
Yes, I just wanted to add how important it is to have that collaboration between the provider and the case manager. I have many years of experience working with Crotchet Mountain Community Care as a provider, although I know technically I'm not considered one, but anyway, it was really important to have that collaboration and have the assessments done from the case manager as to who was appropriate to even be seen. And then once the provider sees it, then they have to survey the scene. It's all and mine was direct care, but to actually then turn that into what is appropriate for whatever you do as a service provider that is appropriate within that provision of care that can be done through telehealth. So I think I like the word collaboration between providers and case managers to be included in the languaging. Thank you.
Thank you, Joan. And Kelly Cappuccino.
Yeah, I just wanted to sort of weigh in and say, I mean, I'm listening to the whole conversation, but honestly, I'm reacting to it as a family member. So, and I know many of you are as well, but so I do think the language obviously is confusing with regard to the telehealth. Clearly, what I'm hearing you say is that you want to ensure that case management is helping people to acquire access if it's an option that they're going to want to use to get their medical services. So making sure that that's what you're conveying would be helpful, because when I hear it, I also hear beyond that. And so all the issues around choice and who I would be working with my provider, I think are very, very relevant. On the other hand, if you're at a mental health center and you're getting services, case management is expected to do exactly this. And if you're somebody who is going to want to utilize telehealth, even if it's not, if it's just for being able to have ways to communicate, to help with your social interactions and such, connectivity is something that we're assessing for in your needs of a comprehensive care assessment for case management. When my brother was with us and he was on CFI, I know that, there's changes now with the Affordable Connectivity Program and such, but if he didn't have me, he wouldn't have had any connectivity. He wouldn't have had anybody helping him to be able to navigate affordability or acquisition. And it's difficult enough to do it when it's what you do as a profession. It was difficult for me, but I navigated it and got it done. It would have been impossible for him and most of the people that I serve to do that. So I do think that it's a very, very important element to be addressing.
Thank you, Kelly. And
yes, Carrie Trummer from Granite Case Management. Ditto on the majority of the prior comments. Just a couple of things. While well intended, whether it's NCAC or the department, words mean things. Sometimes we get into very literal interpretations. And so while well-meaning, you have to be very detailed with your language. So with regards to telehealth, I can assure you, just in managing our agency's IT interconnections to ensure HIPAA compliance is a big challenge. You cannot do that and accomplish that with open networks through a home network easily. That's all I'm suggesting, is to review those applications. On the 3-day notification, unless there's a dramatic uptick in the data collection for accuracy and currency, you're going to exceed that a majority of the time because we have problems with information on application now. And it gets passed through when the participants are agency assigned. And the final comment I would make is collaboratively, I think we'd be a whole lot more productive if there was a conversation to be had instead of proposals made and put forward to various organizations. There needs to be an ongoing dynamic between the people that are delivering case management, the participants, and the oversight bodies like MCAC. Thank you.
And one final
Okay.
question. All right.
Yeah, we're gonna need to, at some point, we're gonna need to cut off comments because we've got the rest of our agenda to do. And what we're gonna do is that, Carolyn has said that she intends to motion for a subcommittee. Any further comments or questions would go to that subcommittee. I don't know.
Okay. I would move that a subcommittee be formed on this rule. I think there are a number of problems with the rule, not the least of which the cost to individual agencies, which is prohibited in the JELCA rulemaking process.
Sorry, go ahead.
Is there?
Yeah, so is there a second on that?
I would second that. It's Kara.
Kara. Thank you.
I would move, so we can vote on it as one motion, that Cara be the lead on the subcommittee. It should be. Well,
How did that happen, Carolyn? Sure, that's fine.
you're doing such a great job, Cara.
So, all those in favor of creating a subcommittee and Cara being, the, lead on that, say aye.
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 Any opposed? The ayes have it.
And I will be on that subcommittee. Lisa Adams, are you still on the line?
Yes, I am.
Would you be on the subcommittee, and is it Kelly, would you? Is there anyone else? Joan? Anyone? Joan?
I'd be happy to.
And are there others that would like to be a part of it?
Yeah, Joan.
This is Lisa Adams. I will take it back to the Home Care Association, and one of us will definitely be on the committee.
If time permits, I would like to.
I'm putting my
Thank you.
email in the chat if anybody wants to get in touch with me after and decides that they're interested.
So if folks have further comments, they can email myself and Carolyn at the MCAG, and we can make sure that those comments get through to the subcommittee. And with that,
Never know that motion.
what was that?
We did.
We did.
Yeah.
Did we complete the vote?
Yeah, everyone
Yes.
said aye.
Everyone said aye, there was no nays.
Okay. Thank you.
So is there a report on the HE-E310 subcommittee?
Yes, there is. Late Friday, I believe, we had a new revision from the department. And I was going to ask Kristen and Olivia today, can you reschedule the subcommittee on the 310 for next Monday at 10 o'clock? If that works for everybody, I can do that.
That's the two
Yes,
at 10.
yes, I think that.
Right, Next on the agenda is the MCA bylaws requirement to approve every 2 years. We are coming up on the 2-year mark of when the members or reports of the members need to review the bylaws and then bring it to the full committee. I would recommend a subcommittee on this to look at those rules and see if any changes ought to be made. So I'm gonna make a motion that we make a subcommittee. Is there a second?
Second, and last time we did this, Holly, which was that 2 years ago or 3 years ago?
3 years ago, right?
Oh my God, I'm now, 2 years ago. Brooke was on the subcommittee.
Brooke is on the line here too.
Oh, she is on the line? I didn't realize that.
I'm sorry, I had to switch modes just for another meeting, but yes, I'd like to be on that.
Yes, so Brooke was on it, I was on it, and I will sign up again. Henry participated with us in most of the meetings. You want to do that?
I will be on it as well. Are there other folks that would want to be on the rules subcommittee?
Yeah, I'm interested.
Wonderful, Kathy, thank you.
The non-exclusive clubs.
Yes. So if folks do want to join, let us know. If you decide after today's meeting that you really want to get involved in this rules subcommittee, let us know and we will get you added. Thank you, folks. And then next, the department updates, Henry.
Yeah, I think we've covered adult dental.
And I sent in an update to Kristen that she's gonna share.
Scott Beckwith, are you still out there?
I am. Good morning, everyone. I'd actually hoped to have a little bit better numbers. But as you can see, for the children's cases, we have a total of 155 cases pending, with 81 of them are over 90 days. For the adults, we have a total of 691 cases pending, with 334 of those over 90 days. Out of the 334 that are over 90 days, 308 of them are in the final stages, so they're ready to be worked on by the medical review team, meaning we've fully developed the record, obtained everything, have moved them to the medical review team, and they're kind of bottlenecked there at this point. We have been in intensive discussions with them over the past several weeks, and most recently last Thursday, they informed us that they've brought on 8 new providers to their staff, and that they are fully prepared to gear this up and move cases out rather quickly. Starting this week, they're hoping to start sending back about 40 cases per week. So we are eagerly awaiting those numbers to see how things are going. I can tell you, just from the end of last week and Thursday and Friday of last week, we did see a significant increase. So now that those additional providers have been onboarded and trained and have access, we are starting to see some progress in the right direction. Somebody had asked me at the last meeting, and I apologize because I don't remember who it was, but they wanted a count of, out of the total adult cases, how many are receiving SSI or SSDI. And so I was able to come up with that number. And so out of the total adults pending, the 691 that are pending, 219 of them are entitled to SSDI or SSI. So out of the total that are pending, 67% of the adults have Medicaid through another avenue, such as Granted Advantage, et cetera, and 30% of the children have Medicaid via another avenue. And that's really all I have to report this week.
Karen, do you still have a question? I can't tell if your hand's still up, but.
It's not. I was just shocked by the numbers, so hoping that the additional staff will result in a reduction and timely decisions. That's all.
Agreed.
So in terms of the other items there, in terms of the Medicaid care management program, we continue to work on the implementation of the features that will be in the 3.0 version of Medicaid care management, the primary care prevention model, the pharmacy changes, and the prescription drug components of that we're actively working on. We expect an amendment 1 to that contract to be in play in June in front of Governor and Council, which would reflect updated rates from what was approved in January. I don't have anything new to report on the HCBS spending plan today. In terms of waivers, that's probably the key update there is the substance use disorder, serious mental illness, 1115 demonstration waiver. The key elements there are the community reentry, that in the presumptive eligibility, that those 2 elements, we're expecting that this full renewal will happen by before the end of June. So I think we're on track to get those things accomplished. That's, I think, what I have for today.
Thank you. Any quick questions for Henry?
I guess one other thing that isn't on here was we did submit under the school-based services grant program. We did submit an application for a grant to get funding to help. There's I think 10 grants competitive nationally to help states modernize their Medicaid school program. For us, it's the key issue is the claiming methodology to be able to do a cost reporting and time study kind of approach, which will allow schools to capture actual costs as opposed to a percentage of the fee schedule. And will hopefully give school districts choices to use additional funding as they see fit.
Thank you, Henry.
Thank you.
And with that, I will entertain a motion to adjourn.
So moved.
Is there a second?
Second, Karen.
Thank you.
Thank you.
Just putting that, we do allow. And.
Back to the last one.